Well, good morning, everybody. Thank you for joining this edition of HD Insights. Again, I'm sorry that we're not together, and I wish we can get together soon, hopefully next year. This year, I think, has been very challenging for many of us involved in clinical care, but I would encourage you that HD Insights has been working tirelessly at communicating important issues for the Huntington Study Group. I just want to give you a couple great statistics that will encourage you. We have about 10,000 readers for our periodical. Our podcast is going really well. We have almost 3,000 downloads for the podcast. And there was a special video podcast episode which reached about 2,000 people. So the total magazine readership has really increased substantially over the last year and a half. And many thanks to Kevin and his team for putting on the podcast and getting them edited and all that hard work. So it's been really a fruitful endeavor. During the HD Insights talk, we like to highlight folks that are maybe new to HD or ideas that are interesting to a broad contingency of clinicians and clinical researchers and patients and families. One of the topics that I have become very interested in is this topic of human flourishing. How can we flourish as physicians, as patients, as caregivers, as clinical research coordinators? And we're very fortunate to have Tyler VanderWeele, who is the John L. Loeb and Francis Lehman Loeb Professor of Epidemiology in the Department of Epidemiology and Biostatistics at Harvard T.H. Chan School of Public Health, to join us today to give us a brief overview of this concept of human flourishing. He's the director of the Human Flourishing program and co-director of the Initiative of Health, Religion, and Spirituality at Harvard University. And for all of us who are interested in statistics, he has done a lot of work on causation models in biomedical and social sciences, and also focused on psychosocial measurement theory. I'm really interested in what he has to say about human flourishing. We talk a lot about resiliency and mental health and well-being, and those are important. But this idea of how we flourish as humans, I think, is maybe a different way to look at an overarching perspective on how we can help our patients, how we can help our families, and how we can help ourselves in terms of thinking about measuring well-being and enjoying our job. It's been a difficult time. COVID has put an intense strain on us as individuals and as a community. But I think this is an opportunity for us to reconsider these important issues. And I'm looking forward to hearing Tyler's perspective. We have another edition of HD Insights coming out in concert with this conference. It's on recruitment and retention, and that's probably related to this topic as well. So thank you for your attention. I look forward to seeing you soon, and enjoy this talk from Tyler.
I'm Tyler VanderWeele at Harvard University, and I will be speaking today on the topic of flourishing in medicine. I'll talk briefly about the concept of human flourishing and also about how to potentially try to assess this empirically in practice. I'll go on to discuss what some of the major public pathways to flourishing might be, and then I will shift the emphasis to ask how and in what ways might this concept of flourishing be relevant for medicine. I'll talk a bit about the potential clinical implications of this concept of flourishing and how I think medicine and clinical practice might move forward making use of this concept and these ideas. More information on the conceptualization of flourishing that I will be presenting today. It's in this 2017 paper in the Proceedings of the National Academy of Sciences, and some initial discussion on the clinical implications of this notion of flourishing is in this 2019 paper in JAMA. More information at the Human Flourishing program at Harvard can be found on our website. So many of our institutions and academic disciplines have very grand visions of flourishing. The World Health Organization's definition of health from 1948, still in place today, is that health is a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. Economics and positive psychology likewise have very expansive visions. But in practice, many of our discussions and studies and efforts are oriented towards addressing much more narrow outcomes. For example, specific disease states in medicine, or simple measures of feeling happy in psychology, or simply income in economics. But flourishing is arguably a much broader concept. If we turn to our dictionaries, the Oxford English Dictionary defines flourishing as to grow or develop in a healthy or vigorous way. The American Heritage Dictionary, to do or fare well. The etymology of the term comes from Latin florere, to bloom, blossom, or flower. It's the word often used to translate Aristotle's eudaimonia, sometimes also translated as happiness. The working definition that we've been using at the Human Flourishing program at Harvard is that flourishing is living in a state in which all aspects of a person's life are good. This is arguably what we're after as individuals, and really should be after as a society, and as I'll discuss in due course, I think has relevance in our consideration of what takes place in medicine. I think the discipline that's come closest to trying to capture this notion of flourishing is that of positive psychology, and many measures of psychological well-being have been put forward, conceptualizations have been put forward in that literature. But noticeably absent from these notions of psychological well-being, which is going to be problematic for medicine, is any notion of physical health, and are we really fully flourishing if we're bedridden or seriously ill? Surely physical health itself, central focus of medicine, ought to be part of some notion of flourishing. Often also missing from these conceptualizations of flourishing in the psychology literatures any notion of character or virtue, contrary to Plato, Aristotle, most of the Western philosophical tradition, and really philosophical and religious traditions worldwide. But with a conception so broad, we might wonder, is it ever really possible to do any sort of empirical assessment? Can we ever achieve any sort of consensus on what this is? And surely conceptions of flourishing will differ across individuals and cultures and religious and philosophical traditions. And while I think that is the case, while I think well-developed notions of flourishing do differ across cultures, I do think one can focus on where there's overlap, where there might be consensus. And so what I would argue is that whatever else might be within one's concept of flourishing, I think any reasonable conception of flourishing would include the following 5 domains of human life. The argument here is not that flourishing is reducible to these 5, but that each of these 5 is arguably part of it. And these would be happiness and life satisfaction, physical and mental health, meaning and purpose, character and virtue, and close social relationships. Again, the argument's not that these exhaust flourishing, but each is a part of it. I think each of these 5 domains also satisfies the following 2 criteria. Each is nearly universally desired, and we have some empirical data on this as well. And each is an end in and of itself. Each of these is sought for its own sake, not merely as a means to some other end. And I think these 2 criteria, being universally desired and being an end, might help shape consensus around what to measure. So it's a very crude measure and assessment of flourishing. We've taken 2 questions in each of these 5 domains, drawn principally from the existing questions that have been used in the well-being literature, questions that have received at least some degree of empirical validation and that are in somewhat widespread use. The only 2 questions which are newly proposed in this flourishing assessment are that in the character domain, and although there's been some very good work on empirical assessment of character over the last 20 years, it often requires a very extensive assessment. There was very little with regard to global assessments of character using just 1 or 2 items. So we worked with philosophers to develop assessments of character based on the notion of the cardinal virtues that at the foundation of all moral virtues lie four: practical wisdom, justice, fortitude, or courage, and moderation, or temperance. And so the 10 questions we've been using in our research with regard to flourishing assessments are as follows. In the first domain, happiness and life satisfaction, we have how satisfied are you with life as a whole these days, scored from 0, completely unsatisfied, to 10, completely satisfied. And this is perhaps the most widely used well-being question in the literature. It's used in the UK's annual survey. It's used by the OECD. It's been used by Gallup and numerous other surveys worldwide. And then we supplement that with a more effective assessment about feeling happy in general. How happy or unhappy do you usually feel? Scored again 0, extremely unhappy, to 10, extremely happy. And then the second domain, physical and mental health. These two questions were drawn from the U.S. General Social Survey and the World Health Organization's survey for mental health. But in general, how would you rate your physical health, 0 to 10? How would you rate your overall mental health, 0 to 10? Then in the third domain, meaning and purpose. First question, overall, to what extent do you feel the things you do in your life are worthwhile? Again, scored 0 to 10. And this question is likewise very widely used once again in the UK's annual survey, by the OECD, by numerous cohort studies as well. And then that's supplemented by something more cognitive. I understand my purpose in life. 0, completely disagree, 10, completely agree. The fourth domain, character and virtue. First question intended in some crude way to assess practical wisdom and justice. I always act to promote good in all circumstances, even in difficult and challenging situations. 0, completely untrue of me, 10, completely true of me. And then a second question intended to crudely assess fortitude and moderation. I'm always able to give up some happiness now for a greater happiness later. And then the fifth domain is close social relationships. These two questions were drawn from the UK's Campaign to End Loneliness, a survey of short social connectedness instruments. First question, I am content with my friendships and relationships. 0, completely disagree, 10, completely agree. This question intended in some way to try to get at the quantity of those relationships. And then second, my relationships are satisfying as I would like them to be, again 0 to 10, intended to capture something of the quality of those relationships. In most of the empirical work we've been doing, we report the scores in each of these 5 domains separately, because as you'll see, the dynamics really can be quite different across the domains. Sometimes we'll also take the average of all 10 as a crude assessment of flourishing, but really this should be understood as nothing more than an average of those 5 more meaningful domain-specific assessments. We also typically in our work supplement these with 2 questions on financial and material stability as important means to sustaining these other ends of flourishing, and these 2 questions drawn from the financial well-being literature are: first, how often do you worry about being able to meet normal monthly living expenses? 0, worry all the time, 10, do not ever worry. How often do you worry about safety, food, or housing? Again, 0 to 10. And so sometimes we'll take the average of all 12 questions for a secure flourishing index, perhaps less satisfactory conceptually, because financial resources are means, not ends, but arguably more satisfactory in practice insofar as indicating flourishing over a more extended period of time. So as an example of how these sorts of assessments can be useful for tracking what's happening to an individual or to a population, we collected data on a roughly nationally representative sample of the United States on these flourishing questions, both prior to the WHO declaration of the COVID-19 pandemic in January of 2020, and also in the midst of it in June of 2020. In January of 2020 in the United States, the average across the domains was about 7, really very close to 7 in each of those domains, except financial and material stability, where we had nearly a point lower, really a full point lower in terms of the mean. Unsurprisingly, during COVID-19, the mean on all of these dimensions, and flourishing as a whole went down, but the domains were affected quite differently. Happiness and life satisfaction, again, perhaps unsurprisingly, went down by about 0.7 of a point. Likewise, physical and mental health, perhaps unsurprisingly, went down about 0.7 of a point. The largest fall, nearly a point, was in financial and material stability. And again, this was June 2020 at the height of the U.S. Unemployment. So big losses in these domains. But also, interestingly, much smaller losses, or in some cases no change at all, with the other three domains. Meaning and purpose went down a little bit, but not all that much. The character assessment essentially was level during these two time periods. And somewhat surprisingly, the close social relationships assessment went down a little bit, but not all that much, 0.2 of a point. And this has been corroborated by other studies looking at loneliness, which showed, again, perhaps surprisingly, that loneliness has increased a little bit, but not all that much during the pandemic. People have found ways to connect with either those they're living with or possibly virtually. Importantly, however, the change in means does disguise variability in experience. And if you look at the standard deviations, those have increased during the COVID-19 pandemic in each of these domains. So while the pandemic may have led some to even better relationships, investing those relationships with those one is living with, for others, perhaps those living alone, this was perhaps a particularly difficult time. But in any case, these sorts of assessments can allow one to see how a particular population or a particular individual is doing in life, and how that's changing over time. So, all this might be fine and good in terms of assessment and understanding, but obviously we also want to be able to promote well-being or flourishing. And I'll first speak about this from the perspective of population well-being, and then I'll move on to discuss potential clinical implications of these sorts of assessments. With regard to trying to promote population flourishing, if one takes the lens of assessing public health impact, often this is done as a function of two things if we're trying to understand the importance of an exposure, phenomena, or intervention. A function of, first, the prevalence of the exposure, how common is it, and secondly, the size of its effects on the outcomes that we care about. Something that is very common and has large effects on the outcomes we care about is going to shape population health. So if we use this sort of lens to think about what are the major determinants for physical health, we're led to things like exercise, nutrition, not smoking, and sleep. But we might broaden our set of outcomes and ask what exposures or phenomena shape not just physical health, but all of these domains of flourishing: happiness and life satisfaction, physical and mental health, meaning and purpose, character, close relationships. What things are both common and have large effects on each of these domains of flourishing. And if we ask that question, looking at all 5 domains of flourishing, we end up with a somewhat different list. And so based on a literature review of rigorous longitudinal, experimental, and quasi-experimental designs, literature review described that paper in the Proceedings of the National Academy of Sciences, I would propose 4 major pathways to promote population flourishing. And those are family, work, education, and religious community. There's evidence that each of these is relatively common in population in the United States and worldwide, and that each has relatively substantial effects on the various domains of flourishing. Evidence for that, and again, rigorous longitudinal, experimental, and quasi-experimental studies. The argument here is not that these are exhaustive. There can be important things for flourishing in one's life, perhaps for some engagement in the arts, say, might contribute substantially to each of these domains, but are perhaps less common in terms of the actual participation. But in any case, the argument's not that these are exhaustive, nor is the argument that these 4 are necessary. One can flourish even in the absence of one or more of these pathways. Rather, the argument is that there's evidence that each of these pathways powerfully affects the different flourishing domains, and so if policy efforts contributed to enhancing and enabling these different pathways, that population flourishing would increase. this sort of diagram provides, taken from the paper, some of the evidence for these claims, the 4 pathways on the left and the 5 flourishing domains on the right, and these little numbers here are references in that paper to, again, fairly rigorous studies from longitudinal experimental or quasi-experimental designs suggesting effects. In some cases, the evidence is quite substantial, and in other cases, perhaps only indicated by 1 or 2 of these more rigorous studies, and more work may be needed. So I could say a lot more about population perspectives on flourishing, but really what I would like to do now is turn to the question of, is any of this really relevant for medicine and clinical practice? And we are collecting data in a number of different settings, in workplace settings and community settings and school settings, but importantly also with clinical settings, mental health patients at Boston University, and cancer patients at the University of Pittsburgh Medical Center, along with medical students and residents at Johns Hopkins, at Medical College of Georgia, at Stony Brook Medical School, and an increasing number of others. So we're trying to understand the flourishing dynamics, both in patient populations and in clinician populations, and also compare this to what flourishing looks like with respect to the general public, both in the United States and with regard to the data that I had showed earlier, but then also worldwide. And we are launching, in fact, a global flourishing study with 240,000 individuals in 22 countries with nationally representative sampling. So we'll really have a sense as to what flourishing looks like worldwide, and we'll be following these individuals up over time with annual data collection to better understand the determinants of flourishing, but also to give us representative data to be able to compare to that in more specific settings, such as clinical settings. And I would like to make the case that flourishing, this notion of flourishing, is relevant, at least in some clinical context. Maybe not appropriate for just a basic annual physical exam, but I do think when it comes to major treatment decisions, a broader notion of flourishing may be important, and it may be important because these different flourishing domains may come into conflict with one another. As a couple of potential examples, one might imagine a man with bladder cancer. A cystectomy would maximize life expectancy, but perhaps substantially hamper quality of life and happiness. Alternatively, a scientist with psychotic symptoms, the antipsychotic medications suppress these, but really impede his capacity to work. Or a woman with a positive BRCA test. Removal of ovaries would protect her against breast and ovarian cancer, but also make her infertile, depending on her goals and desires in life that might potentially compromise her social well-being, purpose, happiness. Or one can imagine a celebrity chef with tongue cancer. Removal of tongue would maximize survival, but would affect social relationships and effectively end his working career. So in each of these cases, physical health comes into conflict with some other end, some other domain of flourishing. And I think in these contexts, inquiring about what a patient considers important across these domains is really going to be critical in assessing with the patient what the right course of action might be. And so, I think this concept of flourishing and thinking about these domains can be helpful in decision making. I think using a flourishing assessment, either the one I've suggested here or there are other well-being measures out there as well, I think that can be valuable also. I think it might improve our research. One can imagine embedding just a simple well-being assessment in say, randomized trials of clinical interventions with which may have substantial side effects, to see not only how the intervention might affect years of disease-free survival, but also the individual's flourishing or well-being. And again, a simple assessment, 12-question assessment, may give one a sense over time what is taking place. I remember a conversation I had with a surgeon who said that in the case of some of these surgeries, cancer, for example, they know from randomized trials that these surgeries do improve survival. But he'd have patients come back to him 6 months later saying they would want to die because the side effects were so severe. So I think by embedding these flourishing measures into randomized trials, we will have a better sense of the trade-offs and may be able to make more informed and evidence-based decision-making, not just with regard to advancing the ends of physical health, but each of these flourishing domains. I think these flourishing assessments might also be useful with regard to the evaluation of care, especially when thinking about sort of medium to long-term assessments. I think sometimes patient satisfaction surveys, well, I do believe they have their role, might sometimes reflect more whether the patient was given what they wanted immediately, rather than how the care itself affected their long-term well-being. So I think these flourishing assessments might be useful in the evaluation of care. I think they might also be useful in the practice of psychiatry, kind of to not just address mental illness, but to promote positive well-being in psychiatry, addressing these questions of relationships, of purpose, of character, which may themselves also be at the heart of some of the sources of mental illness. In addition to I think being useful in decision making and assessment, I think there's good evidence also that a greater focus on well-being, on flourishing, also can help advance the end of physical health. So there are now meta-analyses of a number of longitudinal studies indicating that different aspects of psychological well-being and social well-being, and in fact extend life, protective effects on mortality. So one meta-analysis fairly recently of 10 longitudinal studies suggested that purpose in life reduced mortality risk by about 17%, often over maybe a 10-year follow-up period, risk ratio of 0.83. That life satisfaction, likewise, perhaps more modestly reduced mortality risk in this meta-analysis by about 12%. And that loneliness and social isolation increased mortality risk, possibly by about 30%. So if we were able to address these other aspects of flourishing, purpose, life satisfaction, loneliness and social isolation, that itself could positively affect physical health. I think these notions of flourishing are also relevant for trying to protect against clinician burnout. There's, of course, been a great deal of discussion recently and concern over physician burnout rates being especially high. This preceded the COVID-19 pandemic, but has been exacerbated even further with it. But there's a lot of variation in burnout rates across settings, so trying to understand how promoting different aspects of clinician well-being might improve this issue with burnout, I think would be worthwhile. I think we could pay attention to other aspects of clinicians' life and help them try to address these problems. In one recent study of medical residents, it was quite disturbing when they went through the survey. The domain where they scored the lowest was physical and mental health. So what are we to make of, and how are we to understand the current setting with regard to clinical medicine with those who are to be healers are themselves most struggling in the area where they're intended to heal. Their scores on social relationships were fairly comparable to national averages. On purpose and character higher, on happiness and life satisfaction lower. But again, the lowest domain in this study of medical residents was physical and mental health. These issues, I think, need to be taken seriously and addressed. And there's perhaps some preliminary suggestive evidence that things like finding meaning or having a sense of control or optimism and having psychological well-being may in fact be protective factors against burnout. So again, I'm not trying to suggest that this concept of flourishing is relevant for all aspects of clinical practice, but I think in major treatment decisions, I think in evaluating long-term care, I think in trying to help clinicians themselves, I think this notion of flourishing may be relevant. But in trying to kind of maybe characterize somewhat further what's the role of this notion of flourishing in clinical medicine, I think it can be helpful to try to distinguish between two notions of health, sort of the health of the body and the health of the person, or flourishing. And I don't think the clinician's role is to maximize all aspects of flourishing. I mean, if we turn to that World Health Organization's definition of health as a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity, it's not the clinician's role to maximize all aspects of social well-being. For example, I think the notion of health put forward by the World Health Organization is really the concept of the health of a person, or say flourishing itself. And I think we might contrast that with a more narrow conception of health, the health of the body. But I don't think the clinician's role is just restricted to health of the body either, for some of the very reasons I had mentioned earlier. I mean, principally because treatment decisions affect aspects of a person's life which they care about, which extend beyond physical health. So while the clinician's role is not to optimize all aspects of flourishing in a person's life, again, the clinician's not principally a priest or a life coach or a marital counselor, I think just focusing on the health of the body is also too narrow. So the proposition I would like to put forward, and this was put forward in a response to a letter that came in JAMA to our paper on flourishing, but the proposition I would like to put forward, drawing this distinction between the health of the body and the health of the person, is that the role of the physician is to promote wholeness or health of the person, in other words, flourishing, as it pertains to decisions concerning health of the body. So it's not to maximize all aspects of a person's life, but in any decision concerning the health of the body, one wants to take into account in that decision all aspects of flourishing. So that's what I would put forward with regard to potentially the role of the concept of flourishing in medicine. So does flourishing matter in medicine? Again, I would argue yes. I think it's an important concept, and I think assessments are also important. I think measurement is worthwhile because it shapes what we discuss, and so I think to neglect this concept or the assessment of flourishing, I think really reduces policies and decision making to the purely material, to physical health and financial status. And people do care about those things. They care deeply about those things, but they care about more than that. They care also about being happy, about having a sense of meaning and purpose, about trying to be a good person, about their relationships. And so in decision making for patients and for clinicians, I think this notion of flourishing is relevant. I think it would be good when appropriate to assess flourishing in medicine because, again, patients care about many aspects of life, not just health. And I think many treatment decisions, again, involve these trade-offs across domains. We've seen that psychological well-being can affect physical health. I think this notion of flourishing implies care of the whole person. I think focusing on this notion of flourishing might help prevent burnout within medicine. And I think what we measure shapes what we discuss, what we study, what we know, what we aim for, and the policies put in place to try to achieve this. So I think asking these questions about flourishing has the potential to accomplish these various goals. Flourishing isn't relevant for all aspects of medicine, but I think it is relevant for many. So my hope is that this concept of flourishing, these flourishing assessments, might help us to move towards advancing both the health of the body and the health of the person. Thank you.